Good afternoon, everybody. I have the honor of, first of all, introducing the Marr Endowed lecture, and we have the privilege of Mr. Marr attending the lecture. Mr. Marr is here, and he has been kind enough to get us to bring internationally renowned speakers here to educate us, to give us their insights and learned experience over many years of practice. This being the Electrophysiology Marr Lectureship, I have the privilege of introducing Professor Gerhard Hindricks, who is from Berlin, Germany. He's a leader in the field of cardiac electrophysiology and has been so for the last 2 or 3 decades. He has over 800 publications, has conducted large clinical trials which have altered the way we practice electrophysiology. He is currently going to take over on February 1st as the CEO and the director of the Berlin Charite Trust, which is a huge hospital system. And he has kindly, very graciously flown over yesterday evening and is going back today for a 1-day visit. We are very grateful for Professor Hindricks to come here. I mean, I can go on for his accomplishments over the next half an hour, but it'll be better to hear him tell us his experiences, his clinical trial insights into the management of sudden cardiac death, etiology, management, and so on and so forth. Professor Hindricks, the audience is very large. Because of COVID, we have limited the number of people who come here. They're all online and there'll be a lot of questions. So they're all watching you from different parts. So it's not such a small group. It's a huge group of individuals across the Ottawa hospitals. Welcome. I'll invite Professor Hindricks to come and talk to us.
So, Mr. Marr, dear colleagues, David, ladies and gentlemen, it's a true privilege and pleasure to be here and to have the opportunity to learn a little bit about the Ottawa Heart Center, to meet with all of you here in Ottawa, and to share during this honorary lecture some perspectives on my scientific and clinical connection in relation to sudden cardiac death. I've had 4 beautiful hours here in your institution this morning, and I have to say that I'm deeply impressed about the quality of the medical facilities that you have, the leadership in cardiovascular, academic high-end medicine that you have here at Ottawa Heart Institute, and also, and I consider this really as very, very important, the friendliness of the people. When you walk through a hospital for a couple of hours, you get an impression of what the atmosphere is. You take the vibrations and you see how people are. You see where you get a smile, and you see what doors are open and or may not be open. And it was an exceptional experience this morning. There was so much friendliness. There was so much openness to share ideas and opportunities for the future of cardiovascular medicine. That's why I'm absolutely grateful. This is particularly important for me as I'm taking over, as it has been shared with you, a new position at the Charite in Berlin from February 1st onwards. And we have a settlement which is quite comparable to your settlement here at Ottawa Heart Institute. I was not aware of that fact, that we are so close in our infrastructure, that we are so close in our goals and in the development opportunities, that I would really love to see an even more intense interaction and exchange between the German Heart Center of the Charite and the Ottawa Heart Institute. The governance structure is quite different, quite similar to what we have in Berlin. We, as the German Heart Center of the Charite, have an independent governance structure from the rest of the Charité. We are the pilot hospital within the Charité. We are part of the Charité, yes, but our governance structure, our administrative structure, and also the decision-making and development processes are independent from the Charité. And it's important because it gives you opportunities of being more dynamic in the orchestra of hospitals in the Charité or here in Ottawa. I've learned so much during this 5 hours that I could share with the colleagues here that really inspired me. And this is one of my key take-home message to report to our board at the Charité in Berlin, what's going on here in Ottawa, and what could be the potential opportunities for cooperation in clinical cardiovascular medicine, but also in science and education, and in strategic development of cardiovascular medicine. You see here on the slide the new building of the German Heart Center in Charité. We start digging the hole in the center of Berlin on April 1st. There will be a 4-year period of building, and then we're going to move into that building. I'm the Chief Integration Officer at the Charité. That means that it's my task to in that process to merge 9 different hospitals at 4 different locations into the new German Heart Center of the Charité. And the atmosphere in the discussions this morning was so trustful and so open that I not only discussed this morning the opportunities, but also the challenges that lie into that process. And there are challenges here and there. And I would be grateful if we continue this exchange for the benefits of both sides. And all of you are warmly invited to visit us in Berlin whenever you are in Germany or in Berlin. Just give me a call, and I would be happy to host you at the German Heart Center of the Charité. Talking about sudden cardiac death is probably one of the most important topics in cardiovascular medicine, and one of the most unresolved elements and issues. There are 2 most complex relations in cardiovascular medicine that have, so to speak, followed me during my business career for 40 plus years, 45 years. That's the relation between atrial fibrillation and stroke, and that's the relation between cardiovascular disease and sudden cardiac death. And sudden cardiac death is probably the most complex settlement for sure in EP in that setting. And it's so important, as we will see in the next 45 minutes, because the threats of sudden cardiac death, the burden of sudden cardiac death, and the number of people that are dying from sudden cardiac death, the number of families that are suffering from the losses of their relatives continues to be high in the so-called westernized world, and is tending to dramatically increase globally. That we should not forget that, because global access to care is one of the key elements that we have to address in the future. The inequalities are absolutely unacceptable, and the death tolls in sudden cardiac death are currently paid by the middle-income countries, low to middle-income countries, where you have a sharp increase. It's the same with stroke and atrial fibrillation, and we should not forget that. That's why it's so important that we address the unknowns in and around sudden cardiac death in order to come up with better opportunities of PPP, prevention, prediction, and personalization in the field of sudden cardiac death. I have no conflicts to disclose. I have no industry relations at all, and after my talk, you will understand why a little bit more, a little bit better. So I would like to share with you one of the basic settings around sudden cardiac death that we are in agreement what we are talking about, which is really really important. So the definition of sudden cardiac death and the a clear look on the data that we have in and around sudden cardiac death that relates to the definition of sudden cardiac death must be addressed in order to understand where the misunderstandings and the misinterpretation and the limitations of what we currently have in the field of sudden cardiac death. It's really important to understand that. The burden, we will briefly review where we stand with a global perspective in sudden cardiac. I'm not an epidemiologist, and I'm even less than a statistician in the field, but I have for 45 years now a clinical perspective on sudden cardiac death. And then we talk about prediction of sudden cardiac death. This would be one of the key elements of my talk. I would like to share with you data from I would say the clinical project of my life, which is the PROPHET trial. And then we will take a look to prevention. We will take a brief look to the non-ischemic cardiomyopathies, because there is not that much to learn from the past when we have to reset our perspective on non-ischemics for the future dramatically in order to provide better care for these patients. And then we will look to ischemic cardiomyopathy and look to future directions. There are two things that I would like to share with you. One is the really beautiful opportunity that I had working with the Lancet people on the Lancet Commission to reduce the global burden of sudden cardiac death. The Lancet is really smart. They put together a group of physicians aged below 45. That was one of the requirements to join the group. They may say, well, Gerhard, why did you join the group? You are slightly above 45. Very true. They invited like 3 people that were just called. They worked independently from the 3 people, but we served kind of like consultants to that process. So they under the beautiful guidance of Éloi Marichon from Paris, they developed this consensus paper-like or commission statement, and we were involved to support that process. And I will refer to the PROPHET project. PROPHET is now in year 11 of its development. It's a project on risk prediction to better understand sudden cardiac death following myocardial infarction. So we are in year 11. You have to have a long breath, so to speak, in order to make headway. And I will also talk about a PROPHET a little bit. This is one of the first slides that I did 45 years ago in the relation of in my relation to sudden cardiac death. I was in my early clinical training period, and I worked in animal experimental labs for studies on acute ischemia and the early phases of myocardial infarction. And this is not human. This one from the animal experiments. It was on Harris phase 1A and 1B, early ischemic electrical instabilities and early ventricular fibrillation. And when we did these experiments, I had my first contact to Doug Zipes. Doug Zipes, if you recall the early papers of Doug Zipes, studies on prokinemide in the setting of acute myocardial infarction. And Doug, for the first time, reported in these days that antiarrhythmic drug treatment in the setting of acute ischemia may be harmful to the hearts. And maybe that was before the CAST disaster occurred. CAST came afterwards. And I had my first discussion with Doug Zipes on that topic. And then we went in acute myocardial ischemia and sudden cardiac death experimentally in a setting where we gave flecainide to these animals, and they all died. they all died. So that was my intro to sudden cardiac death, and my exit will probably, hopefully, be PROPHET. And in between, it's then maybe 50 years of clinical contact and science in the field of sudden cardiac death. What we need to know about sudden cardiac death, and that's a different settlement as compared to, let's say, atrial fibrillation, hypertension, diabetes. And it's important because it has a huge impact on the data that we have and the surrounding of sudden cardiac death, that it's a singular and fatal rare event. There's no repetition in many instances. There are survivors of sudden cardiac arrest, yes, that may have additional events in the same setting, but in general, and when we look to the outcome of sudden cardiac death, it's a singular event, and that makes it really complex to understand it clinically and also scientifically. The catastrophe of sudden cardiac death is governed by dynamic risks. They are not static, and we will look to risk stratification from a pathophysiologically and also from a clinically and from a diagnostic point of view. And this is one of the most important insights. If you consider the risks for sudden cardiac death as static, you may fail to understand the key factors influencing sudden cardiac death. They are governed by multiple dependent and independent factors that interact with each other. It's a classical example is autonomic tone, heart rate, blood pressure, mechanical function, and drugs that are continuously altered during ischemia, leading to ventricular arrhythmias and to sudden cardiac death. So when it comes to the definition of sudden cardiac death, and it's really important to understand the limitations of current data sets that we have in the field of sudden cardiac death, definition of a clear phenotype is one of the prerequisites. And we don't have this definition of the clear phenotype. In the ideal situation, we would talk about monitored events, and we would talk about autopsy data and post-mortem data. It's really interesting, and I learned that from working with the younger colleagues in the Lancet Commission group, that post-mortem imaging, for example, is one of the key elements to understand what happened in the clinically suspected setting of sudden cardiac death. So one of the key thoughts that we need to discuss is, what is the truth in what we believe has been allocated to sudden cardiac arrest in our databases, and does it reflect the pathophysiology? And if we talk about rare and singular events, that means that the poison that is brought into your data sets by very few events is substantial. That's different from atrial fibrillation, where you have in each patient 50, 60, 70 episodes, and then you get flecainide, and you have another 50 episodes. In sudden cardiac, you have just this one event. And if this is misinterpreted, then you have a problem, which is very, very difficult to clean up, very difficult. So if we look to, and this is taken from that paper, if you look to individuals that have been diagnosed, allocated to sudden cardiac death, and if they undergo in-depth autopsy, you see that at least 1/3, I think it's 34%, have non-cardiac causes. And they are in your data set as having sudden cardiac death. And if you have 1/3 false positives in a data set with rare events, you may imagine what the effect is when you try to find associations or correlations or causal relations. And we will come back to that topic. You can have the best AI people and the best machine learning people. If you don't have ground truth, you have a problem. And this is one of the key problems that we have around sudden cardiac death. Autopsy frequency goes down. That means what we gain on the field of common understanding, how to diagnose, how to allocate an event to be cardiac death, sudden cardiac death, or non-cardiac death, or sudden non-cardiovascular death. what we gain in that field, we lose in the wrong allocation due to the unknowns in the pathophysiology and the disease setting of the patient, because there are no autopsies. So what is crucial is that we eliminate the non-cardiac deaths from these data sets. Usually there's clinical judgment or adjudication prone to error and misclassification. And it's just honest, in Germany, the emergency physician maybe come from a non-cardiovascular community, and he or she is going to an apartment where there is an element of sudden cardiac death. He or she may not have the expertise to say this is sudden cardiac death, and at the end may have the impression, yeah, well, at the end the heart stopped beating. I don't know the patient, I don't know the individual, so cluck, cluck, we call it most probably cardiovascular, maybe sudden cardiac death. When have you seen him last alive? 2 hours ago. Yeah, it's less. We can call it, was it witness? No, it was non-witness, so you can put it on sudden cardiac death. It may have nothing to do with sudden cardiac death. Various definitions for sudden cardiac death and different time frames and different geographies have applied. We will go to the PROPHET data set, 225,000 individual data sets that should have been adjudicated for sudden cardiac death. They have been adjudicated for sudden cardiac death. But to understand the shortcomings of the data sets and the limitations of the analysis that we were able to perform, this is really important to understand. There is no ground truth in these data sets. And if you don't have ground truth, neither mathematical approaches nor machine learning or AI approaches help you out. So to put that into so to speak clinical pathway, if you have an out of hospital event, out of hospital cardiac arrest, it's not sudden cardiac death, it's sudden cardiac arrest. The patient died out of hospital, then it's presumed sudden cardiac death. Then in good settlements, autopsy, toxicology, histology, and post-mortem imaging will be done in less than 5% of the victims. The rest may be put under sudden cardiac death or sudden non-cardiac death or any other cause of death. But on this path, there are huge uncertainties, because it may be the case that no cardiovascular specialist, not even specialists in sudden cardiac death, may be involved until the patient ends up, or the victim ends up in the sudden cardiac death cohort, and there is almost no opportunity to clean up for that. It gets a little bit more precise when the victim of sudden cardiac arrest is successfully resuscitated and is in a hospital like Ottawa Heart Institute, like Heart Center Leipzig, where experts for sudden cardiac death evaluation are, that know the surroundings of sudden cardiac death, that know the importance of going back to the patient, going back to the family, building up this mosaic like a criminal case to understand what really happens. And my experience is, never believe what has been written up. Always talk to the people that were there, and you will see that your perspective will be different. Talk to the relatives. Talk to the first person who was in the event, and try to come to your own picture and adjudication. And if the patient dies, then from sudden cardiac arrest, dies in the hospital, the likelihood that the grading of the event is more solid and substantial is really higher. And then the few that survive these events, they are survivors of sudden cardiac arrest. If you look to the survivors of sudden cardiac arrest and you try to get a general perspective on sudden cardiac death, there is a limitation, because it's a selected subgroup. There's a lot of bias in this. It may be a specific settlement, specific environment, specific geography, specific state of disease that may be relevant for the individual. Yes, thank God he or she survived, but that may have a limited implication on the general perspective of sudden cardiac death, which makes it even more complex to better predict and prevent these events. The definition for sudden cardiac death that I consider practically acceptable is sudden natural death presumed to be of cardiac cause, which occurs within 1 hour of onset of symptoms when witnessed, or within 24 hours. There it gets really weak. Of last being seen alive when unwitnessed. Sudden cardiac death in autopsied individuals is defined as the natural unexpected death of unknown or cardiac cause. And the definition of sudden cardiac arrest and sudden arrhythmic death syndromes are also given there. It's important to understand the differences. My trial involvement in sudden cardiac death restarted in 2012, actually, 2012. Tom, the animal Lucia, the best editor in the field of cardiovascular journals, that I had the privilege to work 6 years for Tom, and I learned so much from Tom. He's an animal in the publication process. And he invited me and Nikos Dagres, my friend and colleague, to write a review article on sudden cardiac death. And that was there was a gap between the early animal studies and this moment, and this gap was filled with AF. We did the pulmonary veins, and all that stuff was more important. And that readdressed my interest in sudden cardiac death. And Nikos and myself, we reviewed the whole literature that was available in that time. And I thought, I'm damned, in the last 15 years where I lost a little bit track to sudden, that did not happen that much. We implanted a couple of 100,000 of ICDs, but that's it. There was not that much progress. And we reviewed also the burden of sudden cardiac death, and that really inspired us to go back into that field and to try to change something. And I can recall very, very well that I asked Nikos, hey, Nikos, why is nobody working on new data and no new trials in the field of sudden cardiac death after Margaret and Skartev? There was nothing. And Nikos said, no, I don't know. Meanwhile, I know why. I have understood that, because it's so complex. It's so complex, and there are so many specific sites of interest in that settlement that partially prevent progress in science and clinical progress around sudden cardiac death. We will come back to that. So worldwide, between 4 million and 5 million victims died from sudden cardiac death. It's unacceptable, 5 million. And the ICD cannot be the solution for the general problem. It can be the solution for individuals. And we have discussed this morning a beautiful case on sudden cardiac death, on resuscitation after ventricular fibrillation upon exercise, where the ICD was a perfect solution. But it's not the perfect solution if we look to the general problem of sudden cardiac death, and it's far away from a good solution when you look to the global challenge of sudden cardiac death. More than half of all cardiac deaths are sudden, and up to 20% of all mortality in certain geographies, which is significant. 20%. It's really significant, and there is no change. No dramatic change over the last 20 to 40 years. There is maybe a slight decrease in the westernized world that I personally believe is due to the effects that we see in coronary artery disease, atherosclerosis prevention. We will see the linkage the close linkage between ischemia, atherosclerosis, ischemia, and sudden cardiac death. It plays an important role. The age plays an important role when it comes to the incidence. 1 out of 100,000 patient years, person years, not patient years, person years in childhood, less than 40, 50 in the age between 40 and 60, and more than 200 in the age of 80 and plus. But we need to understand, in the 80 plus age, the other causes of death also go dramatically up, because life is not without an end, and people and patients die, median between 65 and 70 years. What do we know about the global burden of sudden cardiac death? We have data on incidence and survival, or both, in few geographies. It's also part of the truth when we look to the global challenge and threat of sudden cardiac death. Basically, North America and Central Europe and Europe have some data, limited data on sudden cardiac death. While the gray part of the world, there is nothing that you can take, or that is known to better understand sudden cardiac death, particularly in Africa and in wide areas of Asia. When it comes to outcome after an event of sudden cardiac arrest, when sudden cardiac arrest turns to sudden cardiac death, there is also there is some improvement in certain geographies that have put a particularly and strong effort on to improve outcome of sudden cardiac arrest. But in general, there has been no change. Overall, there's been no dramatic change. There are huge geographical as well as temporal variations in sudden cardiac arrest outcomes. Overall survival to hospital discharge ranges between 6 and 20%. So that means 80+% will not survive a sudden cardiac arrest. Survival with terrible performance in category 1 or 2, that means a good neurological outcome, is even lower. It's in some studies around 2 to 4%, even in countries in geographies of the westernized world. The percentage of sudden cardiac arrest patient resuscitated and discharged in good neurological state, and that refers to what I've mentioned before, substantially differs between different geographies, different countries, but also within countries, because there are some networks that have been established to establish, support, and optimize the chain of survival for sudden cardiac death, implementing new technologies, digital technologies like first responder app and automatic guidance by mobile digital technology of resuscitation capable people to potential victims of sudden cardiac death. And this is something that I see as a very, very important technology stream for the future in order to improve outcome. It's interesting that in sports-related sudden cardiac arrest, the outcome is better than most other settings. But at the end of the day, it's also not surprising, because usually you don't do sports alone, but you're in the team, soccer team, hockey team, whatsoever. And usually in the environment where sports, particularly when competitive sports are there, there is equipment in order to treat sudden cardiac. That's one side. Another part of the truth is also, if there is excessive physical activity leading to sudden cardiac death, the outcome is particularly poor, even if there is adequate technology and personnel at site. So when we look to the event of sudden cardiac arrest, there is the circle of sudden cardiac arrest with 3 different elements. That is before the event, prediction and prevention, during the event, improving resuscitation, chain of survival, and thereby improving outcome, and then the very, very important management after the event. And the quality of care after these events, at least in Germany, is not satisfying, because we do not have specialized sudden cardiac arrest victim centers that make sure that there is professional assessment, because it's not only in many instances the problem of the victim and the responsibility of the physician for the victim, but also for the families, in order to identify relatives that may be at an elevated risk for sudden cardiac death. I would like to concentrate, because this is the field of my my research and my interest on the phase before the event and talk a little bit about prediction and prevention. Starting with the figure that has been shown more frequently in many adaptations as most of the other. I think David, we've seen that 45 years ago, 40 years ago, for the first time in a slightly different format from Bob Meyerberg, which is, it gives one of the basic insights into the challenge and the problem around sudden cardiac death, which is risk versus absolute numbers. And the key message you see here, the general population, and then it comes down to populations with an increased risk of sudden cardiac arrest, peaking at the ones that had sudden cardiac arrest, and gives the absolute numbers that may be affected in that specific settlement. And it's 40 people that are giving you 4 million victims of sudden cardiac arrest. And as you can see, the more specific you can be in order to go into risk prediction, the higher the risk is, and with a high event rate, you naturally have a better intervention outcome, the fewer the impact is on the total problem of sudden cardiac arrest. So if you would be effective to prevent sudden cardiac arrest in 20% of the general population, you would do more to the problem as compared to 100% effectiveness in the resuscitated sudden cardiac arrest group. And to find the right balance, where to go in with our research and with our interventions is also a true challenge. I just mentioned the crucial relation of coronary artery disease, atherosclerosis, and the sudden cardiac death incidence. In the vast majority of victims of sudden cardiac death, structural heart disease plays a role, and it's coronary artery disease leading to acute ischemia, leading to the figure that I showed you from the animal. And that's the typical event of early VT, polymorphic VT-VF in the setting of acute ischemia, leading to sudden cardiac arrest with polymorphic VT and VF. It's the biggest field, and the size of the portion here in the graph indicates that. And then there is the non-ischemic cardiomyopathy, also structural heart disease that plays a role for sudden cardiac arrest prediction and prevention. And when it comes to more specific electrical diseases leading to sudden cardiac death channelopathies, the number is almost not relevant for the general problem of sudden cardiac death. So if you want to change something in the general perspective on sudden cardiac death, we have to approach this field, the red field. The red field is where the big fruits are that we can change something. Up to 40% of sudden cardiac death victims have had MI on autopsy without knowing it. It also shows the difficulties of adjudication, and also the difficulties of risk prediction when it comes to phenotyping of the patient. You need to know that the patient had remote myocardial infarction in order to understand the role of remote myocardial infarction for the ischemic event, because an ischemia which continues to push on a remote myocardial infarction has more deleterious effect than ischemia that does not approach a fibrotically diseased heart. The field of non-ischemic cardiomyopathies will only very, very briefly touch, because this is an ongoing disaster for the last 40 years that has just started to be a little bit reworked up. The group of non-ischemic cardiomyopathies for decades was taken based on the common finding that they don't have another disease. That was a common ground for non-ischemic cardiomyopathy. They don't have another disease. They don't have coronary artery disease, and that's qualified them to become an entity that has been a group that has been seen as an entity. The pathophysiology, the risk, everything is absolutely different in that subgroup. Maybe from low to close to zero to an annual risk of 10 to 12% for the laminopathies, 15% per year sudden cardiac death rate, to close to zero in non-fibrotic forms of dilated cardiomyopathy. And they all have been summarized and grouped to one entity, non-ischemic cardiomyopathy, because there was no coronary artery disease. And if you look to the outcome data of the old trials, we have to put them simply end of life, take them out. We don't want to see them again. They have nothing to do with our understanding of non-ischemic cardiomyopathy, and they have nothing to do with the quality of care in these channelopathies we have already touched. There are various risk ages, triggers. This is the central figure from the 2022 ESC guidelines, not 2023, on sudden cardiac death and sudden cardiac death prevention. I like that figure because it transfers a lot of important information around from the field of ventricular tachycardia, ventricular fibrillation, and sudden cardiac death, as it clearly shows that there are specific triggers that may be relevant for disease subgroups that are prone to develop ventricular tachycardia and sudden cardiac death for different genders, males and females, and at different ages. The age plays a crucial role for the different subsets of disease. And interestingly, and this is one of the main achievements of these guidelines by Katja Zeppenfeld and 12 Hansen, that they stopped talking about non-ischemic cardiomyopathy as one entity, and that they separately address them. What is really crucial, and it also indicates the different types of arrhythmias that may be relevant in that setting. We will now focus on non-ischemic cardiomyopathy and address a little bit where we stand with risk stratification to predict the risk for sudden cardiac death in ischemic cardiomyopathy following myocardial infarction. This is one figure taken from the review article that Nikos and myself wrote in 2013, and summarizing the high part of the high complexity of risk factors that lead to sudden cardiac death in that setting. Patient-related risk factors, ischemia as one of the risk factors, acute, recurrent ischemia, chronic ischemia, that is modulated by the autonomic tone, and the autonomic tone also modulates the influence of the ischemia per se, resulting in electrolyte abnormalities and promoting the well-known basic mechanisms of arrhythmias, and the different approaches in order to understand the risk factor, to measure the risk, and to transfer the risk into a protection algorithm. So, and I worked with Günther Breithart. David, you know Günther well. Günther for 10 years measured late potentials. And when I was trainee, I had nights and weekends to measure late potentials in order to predict sudden cardiac death. Who's talking about late potentials anymore? There was no progress, and it had no effect, as it was a single measure which addressed only a small spectrum of what may be relevant for the individual risk for sudden cardiac death. Acute restoration, micro T-wave alternates, ectopy, late potentials, turbulence, heart rate variability, baroreflex sensitivity. In the 90s, we did huge trials with baroreflex. ATRAMI was one of the hugest trials in order to identify modes for risk prediction following myocardial infarction. No strategy proved effective. preventing some to achieve guideline relevance. None of them. It's all on ejection fraction. And the limitations of ejection fraction are well known to us. But ejection fraction is the only risk stratifier that kept in the guidelines. And we paste and copy that from guideline to guideline. This was something that really surprised me. That was in an AHA statement from 2011, because it's too depressive for me. Given the relatively poor performance of current risk stratification approaches for sudden cardiac death and the aforementioned various challenges and limitations, basically the stuff that we've discussed, it is reasonable to query whether further efforts should be devoted to this area. No, never give up. No, this is unacceptable, and I still don't understand how the reviewers could accept such an official statement of the American Heart Association in 2011 to better understand risk stratification and risk prediction. So simply don't look at it. Do something else. What do current guidelines recommend? I will speed up a little bit that I can at least share with you a little bit from profit. Guidelines recommend a class 1A post-myocardial infarction, symptomatic heart failure class 2 to 3, ejection fraction less than 35% on optimal medical 1A recommendation, which is based on these two trials. Artemis and Margaret, beautiful, but 25 years old. Gasbardi and Scartaft, beautiful, but 20 plus years old. And the results of these trials, they simply do not reflect the quality of care and the patients, the characteristics, the phenotypes that we have currently. When I was in the sudden cardiac death guideline in 2016 with Silva Priori, I voted for EOL, end of life, for Margaret 2 and Scartaft, and said we simply should write, we don't know, because the impact of these trials on the current, but there was no courage to do that. So what we did was we copied, and everybody was unhappy. It's just between us because it's from the internal discussion of the guideline type, but it's almost 10 years old. We discussed it, everybody was unhappy, and everybody said, yeah, Gerhard, that's not wrong. Yeah, it's pretty old, and no, there is not that much impact on today's medicine, but let's take it and copy, and we copied it. Most of the evidence then was generated by meta-analysis, and a quick look to the really lousy settlement in non-ischemics. This was before the Danish trial. This was relevant evidence for hundred thousands of ICDs implanted in non-ischemic cardiomyopathies, and we talk about 110 versus 149 events of all trials that were included. None of the trials was significant. None of it. Even Scartaft was not significant for the non-ischemics, and not talking about Amioviat, 7 versus 9 events. So we simply should say, okay, it was a mistake. We apologize and we delete it. We simply take it out. Yeah, I jump over this. It's non-ischemics. It's not worthwhile to go in depth because we have only like 5 minutes left. What are the current data to support the guidelines? I will speed up a little bit. This is because you are doing what you're doing. Improved care in cardiovascular medicine, interventions, medications, pacemakers, CRTs. They're really taking care. This is the true success story in medicine of the last decades. It's in cardiovascular. It's on us. We did it. We reduced mortality from heart failure to an extent where our friends from oncology, with all respect due, will dream of in the next 50 years. The decrease is dramatic, and that's also true for sudden cardiac death. There's a dramatic decrease in the incidence and importance of sudden cardiac disease. These are the big trials, and if you just over the thumb see what is the the percentage of sudden cardiac death. We had, in the 90s, we had total mortality of 12, 13, 15% in heart failure population. It's down to 6%. Sudden cardiac death rate of 6, 7%. It's down to 1 or 2. Because of, and these data, because of improved care. And these data do not even include the effects of SGLT2 and sacubitril/valsartan. It adds on minus 25% for sacubitril/valsartan and SGLT2. So a completely different setting as compared to more data showing exactly the same. Showing that the environment has completely changed. The patients have changed. The quality of care has changed. Then it's just understandable that the role of the defibrillator must be questioned in this settlement. Look to these data, appropriate shock rate in various settings of clinical trial. MADIT2 was high, and there is a reduced shock rate, intervention rate due to advanced programming, MADIT-RIT, and yes, but it's also because of the improved quality of care. Improved acute interventions in the cath labs and early adequate guideline adherent therapy, full dosing. That what we are doing, what you're doing, push the patient, bring it to the limit of advanced pharmacotherapy. And in an ICD register, even 2014, it was 1% appropriate shock rate. 1%. Oh, single one. So this summarizes what I've said. With total mortality up to 8, 10%, 5% sudden cardiac death, there's something to gain for the ICD. In this settlement, there is nothing to gain for the ICD. So, and that's why we went into profit. And I take the last 5 minutes of my presentation to share with you the lessons that I've taken from profit. Some of them were surprising, some of them were painful, but they were very important because they gave us some insights that were not known before. Profit was a project. In 2013, I said, Nikos, we need to do something. We have to look for new data. So I flew to Minneapolis between us, and I visited the usual suspects. I went to Medtronic, I went to Boston, I went to Abbott, and with the idea to do a new ICD trial that includes everything that we've just discussed. And I talked to Ken Stein, I talked to the big guns. And I said, here's my plan, and we're going to do that, and we make medicine better. And he said, yes, Gerhard, we share with you the importance of the idea, but it's not in our priorities. So we did not get any money. It was the same. I know these people, and of course, it's not in their priorities because they will. It's very unlikely that there will not be a substantial change. So then we went to the European Commission and we applied for a grant of 10 million, and it was rejected. It was 146 applications, 6 were taken, and we were number 7. Number 7. And they said, okay, don't worry, you're on the waiting list and you will jump up. And then they said, no, you're not gonna make it. For 3 months, I did not look to anything related to that. I had a lot of beer, but I did not look to the application. And then I learned again the value of failing. We did another application for profit then a year later that was substantially better than the first one. Substantially better. And it was 24 million. So it was substantially more expensive. We got the money for profit from the European Commission. Independent, industry independent. 24 million euro to do the re-evaluation of the risk classification for sudden cardiac death. And it's a 3-step approach, re-evaluation of existing evidences. And we will briefly revisit and summarize what we've initially discussed, what the weakness of the data are in re-evaluation of existing evidences. Second step was intended to be development of a risk predictor. And then we intended to go into two randomized clinical trials with 3,600 patients incorporated, profit preserved and profit reduced, with ejection fraction below 35% and ejection fraction above 35%. This is a consortium. And I would like to share with you our approaches to improve risk prediction based on data that we gathered from 220,000 patients adjudicated for sudden cardiac death from 19 data sets. And you see the data sets and the left ventricular ejection fraction. We had the full range of ejection fraction. It was from SCATEF, from Margaret, from the Swedish registry, from the Israeli registry, from German data sets. And we did two approaches in phase 1. We tried to assess in this big data set the value of left ventricular ejection fraction, and then we included up to 80 parameters that we had from the data sets in order to come up with a model that improved risk prediction for sudden cardiac death above left ventricular ejection fraction. And to make it short, we failed to achieve that. It was a very complex mathematical model in Manchester. 20 people worked for 2 years on this data set to clean it up, to make it as solid as possible. And then there was this rotating leave one out model, where you then do a meta-analysis and you sum up. And then in phase 2, we had 3,000 patients with MRI data. We also worked on the MRI data. I share with you the key findings. Left ventricular ejection fraction alone in patients with ejection fraction of less than 35%, area under the curve at 12 months for sudden cardiac death, 0.52, which is not so strong. 0.5 is just throwing a coin. The Weibull, we had two mathematical models. It's the same. And then we had two machine learning, one machine learning and one deep neural network model that also did not improve. And that brings me back to my initial discussion. When you don't have ground truth, you can do whatever you can. The data sets are simply not strong enough in order to improve. That means we have to completely, it was impossible with whatever we did to improve the prediction for sudden cardiac death in 200,000 patients. We cooked it down to 145,000 to keep out every weaker data sets, but it did not improve. It did not improve everything and anything. And the key message is, because there are too many false positives and false negatives in the data set, and you cannot clean up for that. No AI algorithm will be able to clean up for that. The MRI did also not substantially improve. 0.59 and 0.62, little bit better, but not substantially better. So if you look to pooled data sets from MRI for these data sets, we had for almost all data the original data sets, and they were re-evaluated, homogenized. Whatever has been published in the literature could not be confirmed with these pooled data sets. A lot of what is published on the strong predictive power of MRI is based on single institution data sets that are full of bias. Whenever they come to external validation, they drop down. So I close now with what we're going to do with profit. This was the initial plan. 1 minute, then I'm done. This was the initial plan. We learned risk prediction, and the development of a risk predictor was not possible from the data set. It really gave me some days of deep depression. And then I talked to the European Commission and said, what are we going to do with that? What are we going to do? And they said, continue. You have to continue. And we continued, and we changed the protocol. It took us 1 year, and we are now doing the following. We have fused the two clinical trials to a single one, and it's basically Margaret revisited that we have started. We have the first patients included into the profit trial. We will focus on the the population with less than 35% ejection fraction, because the sudden cardiac death rate in the more than 35% ejection fraction was below 1%, according to the analysis. No trial could ever be done with such an incidence. So we will randomize 3,595 patients in almost 200 centers in Europe, sponsored by the European Commission, and reevaluate the added value of the ICD over optimal medical therapy in a non-inferior trial design as compared to optimal medical therapy alone. And it will be my privilege, hopefully, that this will close my personal experience and loop with sudden cardiac death. And I have the privilege to report the results to you someday in the not so near but visible future. And I thank you very much for your attention. And I apologize for having talked too long. Yeah, sorry.
Thank you for that wonderful insight into the evolution of sudden cardiac death risk assessment and the failures in trials and tribulations. I hope I'll be retired by then, because if this trial shows no benefit for ICDs, half my job description will be done. So it'll be good for the community, but maybe I won't have the need for EP labs and doing procedures.
No, I mean, we should not forget that despite the fact that sudden cardiac death rate seems to be low in the preserved ejection fraction population, if you go for the absolute numbers, and it refers to one of the items that we have already discussed, the number is by far higher as compared to the reduced ejection fractions. That means if we would be able to identify on a personalized, precise level, the high-risk patients with preserved ejection fractions, the volume of ICD implantation would be potentially 4 times as high as it is today. We leave this population totally unprotected. Above 35%, primary prevention, 0. So I wouldn't be so, well, I would say negative in the expectations on our career and job perspective.
I think anybody who has a question, I think Dr. Green wants to speak, but before that, we have a question from Michael Cheng online. Professor Hindricks, will your new team use AI in the prevention of cardiac deaths? Can AI be used as a patient education tool to motivate the general public to minimize SCD risks? Thank you.
Yes, we will use AI applications in that field as well, but we can give it a meaningful application only if we have data sets that fulfill the expectation on sufficient ground truth. If we don't have ground truth, it's misleading, and there is nothing we can do to correct for that. The team from Niels Peak that analyze the data, they are professionals in risk prediction. They do only risk prediction in medicine, and they analyzed with internal and external additional expertise the profit data. It's the biggest data set on the planet. There are no, if we have forgotten any data, write to me and we will redo it. But the adjudicated data for sudden cardiac death, 225,000 aggregated, cleaned up. There's no way to resuscitate this data set and to clean it up. But this is now something we have learned. When we go into the prospective arm of profit, we will make sure that we create ground truth, that we prospectively will do a perfect phenotyping of the patients, that we will look to the genetics, to the genomics, to the proteomics of the patients, to have these data then available, clearly then adjudicated to events. And this will then, of course, allow to apply machine learning and artificial intelligence for risk prediction. There is this paper from Natalia Trajanova on AI algorithms to predict sudden cardiac death from raw data from the MRI. It's in Nature Cardiology. It's an interesting, I know her very well. I respect her. But again, data came from a single data set And if you go to external validation, and she did some external validation, you see that there is a substantial drop in the predictive value. So I'm not on a short to midterm expectation. I'm not so enthusiastic about AI applications to predict sudden cardiac death. And the fact that we have addressed before, that it's a rare and singular event in most individuals, absolutely limits the application of these technologies.
That was wonderful, Gerhard. That was a historical, educated perspective on sudden cardiac death and on data sets. In Ontario, I'll just do a little bragging. So our province here, we have a fairly robust death investigation system in people under the age of 45 who die suddenly. That includes autopsies, examination of the heart, genetics, and storage of genetic materials. So this has been going on for 15 years now, and there are hundreds of cases. And I think Denmark has a similar, and there's a few other jurisdictions, not many, who have done this, but I do have some hope that more will come out of this with large data sets that are very inclusive and well studied. I hope so.
Yeah,
that was wonderful. Thank you.
It's really necessary, and that's good news.
Yeah, I was there for Natalia's presentation at Copenhagen when she presented the MR data set. But I'm reminded of what Dave Sackett once told: if you put garbage in, you'll get garbage out through any machine. So that's the problem, is the veracity of the data you're feeding in to make conclusions. And hopefully, such a big project from Europe will help us. Any other questions from our sudden cardiac arrest perspective? Oh, Dr. Lu.
Yeah, this is again, congratulations, and I've been following this field very carefully, and I apologize as a heart failure specialist that, I'm putting half of my colleagues out of job, but we need many colleagues to help out with heart failure. And so one of the key areas, for example, you're looking at a heart failure with preserved ejection fraction, is our realization at the present time is the heterogeneity of the population. And that, an etiological in the very, very fine phenotyping, in fact, is actually critical for us to actually achieve any sort of impact in that disease process. But you're absolutely right, the rates of sudden cardiac death is quite different amongst the different subsets. And I do think that this your approach thinking in terms of better characterization of the subgroups of the patients with sudden death will actually give you that set of tools. Do you think this is kind of the approach that will be?
I agree that is the approach that we need to follow. It will be interesting to see what the genomic side of the sudden cardiac death prediction may add to that. We try to implement genomic tasks, data in the old risk prediction. They're not there. I talked to Arthur Wilder, I talked to Silvia Perori, I talked to Peter Schwartz. Is there anything we can take? It is something that we now prospectively need to do. The phenotyping of the victims in their various phenotyping, genotyping in their various settlements. It will be a key to better understand and then to better predict. And one, maybe from my side, last sentence to the importance of heart failure treatment, looking to these figures with a decrease in mortality. The interpretation is crucial, and the interpretation that the problem of heart failure is solved now is completely misleading, completely wrong, because the prevalence of heart failure patients that reach more advanced stages of disease will substantially increase, and it's beneficial. It's a huge success story that mortality rates go down, but we need to intensify and strengthen our heart failure programs, because the expectations of the patients, the needs and requirements for treatments, they are there in the heart failure segment, but this is a completely different topic. I believe that that healthcare anywhere, home treatment, and digitalization will play a key role.
One last question is, a lot of this data on ischemic cardiomyopathy was from the pre-primary PCI STEMI programs that preventing many. Do you think that like most of the clinical trials had 65 to 70% ischemic cardiomyopathy?
Yeah.
But those who do VT ablations don't see any classical large cars. We see only, and so I think maybe this population is going to go down, and the non-ischemic dilated HFrEF population is going to rise. And is that something you observed or have observed, or you have any insight?
Absolutely. I mean, the classical finding that we had in the 90s, in the 80s, in the 90s with these huge anterior wall aneurysms, because there was no system for early revascularization, resulted in a pathophysiology completely different from what we see currently, where infarctions are fortunately smaller. That has an impact on the architecture of the infarction. The hemodynamics are usually preserved and better as compared to the huge balloon-like aneurysms that we saw from these days. And many of the patients that led to the result of MADI-2 were these huge aneurysm patients. There's one question from you. Yeah.
This was fantastic, as Marty and Gerhard already said. Really fantastic presentation. I learned a lot, and I really commend you for challenging dogma with this trial. It takes a lot of courage to do that. And my question to you is, do you think these 180 centers have the equipoise to enroll the patients?
Yeah, that's a key question. I would start with a sentence that I've used before: never give up. So push, push, push. It's simply necessary. And there is a very interesting comment on exactly that question from John Mandrola in Medscape. He in one of the last Medscape podcasts, he focused on profit, and he said, guys, we have to do it. We have to do it. It's impossible in North America, in the US. He said, in the US, it's impossible. Nobody would do that. Right. But you should do it in Europe. And he said, it's important. So there are two things. One is, I need your support. We need your support. So whenever you talk about profit, give it support and push the people to include patients. There are centers we are currently calculating with 0.4 to 0.5 randomizations per institution per month, which would then 200 institutions, 0.5 would be 100 implantations. Then we would need 3.2 years in order to complete the trial, and then another 2 years. It's an event-driven trial that we have enough events. And there are centers that are 2.6 implantations, randomizations per month, 2.6. So it is possible, but it deserves very, very good communication strategy and the support of decision leaders like the ones that are here in the room, in order to further promote the urgent need for fresh data. We do another project, which is Reset CRT, where we have randomized 1,000 patients CRTD versus CRTP. That was also a trial where I asked the industry, and they said, not us. And people said, this trial will never be done. And I said, it will never be done until we do it. And we have now 1,000 patients randomized, and we have almost 200 events, almost 200 events. We need to wait another 2 years. Then we have 326 events, and then we will see whether the costs for a D and the pain for a D in this subset of patient results in better quantity of life. And so that's why I'm so enthusiastic also about presentations that I had the opportunity to share with you, just to multiply the people that know the project and that would help us to promote the project, that we can bring it to a successful end. We will have a review by the European Commission in summer. We are 18 months behind our plan because of there was no risk predictor, and we had to reset the whole trial, and there was COVID, then there was so I hope that the European Commission will say, okay, it's an important project, we promote it, and it's very well possible that one of you will be invited to write a review on for the European Commission then. Please support us.
Thank you, Professor Hindricks, and thank you, Mr. Marr, for as ever for fostering scientific inquisitions into different disease states. Thank you.
Thank you.
Until next year.